Welcome. Our system this week is respiratory, so we'll be talking about respiratory pathologies and the pathophysiologies that go along with those pathologies. Let's first take a look at the overall outcomes or objectives. And you have these listed, so I'm not going to review them because I'm going to break these down into pieces and parts. Please be sure that you note the last area of focus. You are responsible for reviewing pulmonary embolus. We've talked a little bit about that before, so I wouldn't spend a lot of time on that, but please do review non-small cell and small cell lung cancers. So this first piece that we're going to talk about, we'll do an introduction and we'll look at restrictive processes. We'll also take a look at pulmonary edema and acute lung injury. So we'll clarify the difference between hypercapnia and hypoxemia. It's important that you be able to identify the difference between pneumothorax and pleural effusion. And when we talk about pleural effusion, we're going to talk about transudative and exudative. And I do expect that you'll be able to differentiate the two. In the some of the other pathologies, we'll take a focus on the restrictive to start with. And then I also want to talk a bit about pulmonary edema and acute lung injury. So let's start with the alveolar capillary level because that's where gas exchange occurs. We want to remember in our normal physiology that airways conduct, but they don't participate in gas change. Gas exchange occurs at the alveolar capillary level, not in the airway themselves. So when we think about what we mean by hypercapnia, we're talking about an increase in the arterial pressure, the partial pressure, the arterial CO2. So when we think about that arterial CO2 then, one of the things we want to keep in mind is hypoventilation of the alveoli. Remember that carbon dioxide is produced by the cells, and when we have hypercapnia, the amount of carbon dioxide that is being produced is greater than that of what's being removed. Therefore, the arterial CO2 content begins to increase. So, as a result, then, the other thing we have to think about is minute ventilation, because minute ventilation determines our CO2 removal. Minute ventilation is how much air we move every minute. And so that's actually a calculated value. It's our respiratory rate times our tidal volume. Now we also know that CO2 can result in a respiratory acidosis, because remember, when we're thinking about hypercapnia, we're talking about production being greater than removal, therefore we're retaining it. That means we would have a respiratory acidosis. So as a result then, let's think about some overarching pathologies that might actually cause hypercapnia. So certainly something that would decrease the respiratory drive or conduction of our impulses to help us with our respiratory drive. So that's where we talk about sedating drugs. We think about a traumatic brain injury or brain trauma because we're losing those impulses, or we've lost the impulses to breathe through the brain trauma, or with sedating drugs we've decreased that respiratory drive. Because remember, one of the reasons that we breathe is because we increase the CO2. We have an increased level of CO2. Other pathologies would include neuromuscular disease or even infections. Polio, great example. We don't see a lot of polio anymore, but you may see a polio survivor who now comes back as an adult with some chronic pulmonary issues. Think about diseases of the neuromuscular junction, like myasthenia gravis. Again, more likely to see that in an adult than you are in a child. What about airway obstruction? Big thing I always think about here is obstructive sleep apnea. Although a lot of the work that we've done in obstructive sleep apnea focuses on adults, we are seeing obstructive sleep apnea in children as well. And one of the variables in the development of obstructive sleep apnea in a child is morbid obesity in a child. Other pathologies that we should consider in hypercapnia include anything that increases the work of breathing or increases the dead space. Dead spaces are parts of the lung that are not contributing to gas exchange. So as a result then, when you have more dead space, there is less perfusion even though they may be ventilating. So dead space means they're ventilating, not perfusing. And this is actually what we see in emphysema, a chronic emphysema. Pulmonary embolus increases our dead space. And we are, again, ventilating, not perfusing. The other thing we want to remember with hypercapnia is electrolyte disorders with acidosis. Remember that CO2 exists as bicarbonate within the body, and that's how we affect our acid-base balance, as well as that retained CO2 in our lungs. Remember, with an acidotic state, we would not be surprised to see hyperkalemia, hypermagnesemia, and hypercalcemia. So all of those things. Remember, our acid-base balance is very, very important. So what about hypoxemia? Well, we know that oxygen enters the plasma, a very small amount. It's in the plasma, and it exerts a partial pressure. Once the oxygen is in the plasma, it binds with hemoglobin until it's saturated. So then what we have to think about is alveolar, the pressure in the alveolar system as well as that in arterial system. So the O2 enters the plasma, exerts that partial pressure, binds with the hemoglobin. When the alveolar and the arterial pressures are equal, there's no more diffusion across that red blood cell membrane. And that's an important concept that we always want to remember, because remember, we're talking about pressures. So when alveolar pressure and arterial pressure are equal, no more diffusion of oxygen can occur across the red blood cell membrane. So when we think about hypoxemia, then we're talking about a decrease in the arterial, the amount of oxygen in the arterial blood. Now, this is different from hypoxia. Hypoxemia is what we're talking about in the circulation in the blood, as opposed to hypoxia, which is the amount of oxygen in the cells in the tissues. So once again, what kinds of things should we be considering? Well, we should consider anything that decreases ventilation of the alveoli. We would want to think then about a mismatch between alveolar ventilation and perfusion. Remember, ventilation is the amount of air in the alveoli. Perfusion is the amount of blood getting to the alveoli themselves. And this is what we call a VQ mismatch. So what we're talking about with this mismatch is perfused areas not ventilated or ventilated areas not perfused. So let's take a look at an example of each one of those. So again, mismatch just means that there's a mismatch between alveolar ventilation and alveolar perfusion, which is the amount of blood in the alveoli. See, the amount of air in the alveoli, the amount of blood in the alveoli. So if we look at areas not ventilated, that are perfused but not ventilated, this is what happens in a pneumonia. You have all those infectious secretions or some sort of secretions that's actually in that airway. And so although the alveoli are being perfused, they're getting plenty of blood, the airspace, the airway space is not being ventilated. The second was a ventilated area not perfusing. So this is what happens in a pulmonary embolus. You've got a clot sitting on the vascular side, and then you have, but the airways, the alveolar part is still open. So it's a VQ mismatch. We always want to be sure that we think about perfusion of the pulmonary capillaries. That makes sense, because if you can't perfuse those pulmonary capillaries, there's not going to be much gas exchange. And then the last thing to think about is the FiO2, or the fraction of inspired oxygen, as well as the minute ventilation. So FiO2 would be important, how much oxygen is actually in the inspired air, because if you don't have much oxygen in the inspired air, that could certainly lead to hypoxemia, as well as, remember, that minute ventilation. Minute ventilation is the tidal volume times the respiratory rate. Tidal volume is the normal amount of air with inspiration and expiration. And that's generally about 70 mLs per kilogram. So let's take just one more look at that alveolar to arterial gradient. What's important is when we look at that difference, we're assessing the integrity of the alveolar capillary unit. So if you have an increase in the gradient, in the alveolar to arterial gradient, oxygen is not effectively transferring from the alveoli to the arterial side. So there's normally a difference in those two, and the normal is about 5 to 10 millimeters, millimeters of mercury. And that tends to go up just a little bit with age. Let's look at some pathologies then can actually either lead to hypoxemia or hypercapnia. And we're going to do this, and so before we address restrictive or obstructive or inflammatory, let's look kind of outside this gas exchange level for just a little bit. And that's really what the pleural disorders are. Remember that that if we do anything in the pleura, just like the heart, the lungs are surrounded by a sac and there's a small space in there. So anything that we do in the pleura can actually alter negative pressure, and negative pressure is necessary for that gas exchange to be assisted. Two of the biggest things you'll run into is a pneumothorax and a pleural effusion. And again, these happen at absolutely all ages, whether this is a neonate, a premature neonate, a term neonate, a child, or an adult of any age. So a pneumothorax is air in the pleural space, and these can be spontaneous, traumatic, or even there's something called a tension pneumothorax, which you've probably heard of. A spontaneous pneumothorax is generally due to a bleb or a bullae that has ruptured. So this would be a weak area within that alveolar capillary area that is actually ruptured. Most of these tend to occur at the apex. And why they occur at the apex is somewhat unknown, although this might be a slightly weaker area in most of our lungs, because remember, we don't have a lot of alveoli up there. With a traumatic pneumothorax, that's just it. You've hit the steering wheel. Someone has a gunshot wound, something of that nature. When you have a tension pneumothorax, you have a shift of the mediastinal structures away from the site of air entry into that pleural space. So someone comes at you with a knife and they stab you on the left side. So as a result, then the mediastinum is going to shift to the right, because it's going to shift, it's a tension pneumothorax, shifts those mediastinal structures away from the site of air entry that is entering that pleural space. And that sort of makes sense, because you got this big old air bubble sitting there and it's mushing everything over. The second pleural disorder that you will experience, that you will see in patients, is a pleural effusion. And pleural effusions are generally transudative or exudative. And it's important that you be able to differentiate between the two. A transudative pleural effusion is a watery pleural effusion. Now remember, this is fluid within that pleural space. It's not in the lungs, it's in that pleural space. This is usually due to an increase in hydrostatic pressure in the intravascular space, or a decrease in the capillary oncotic pressure. So what you'll see with a transudative, you're really talking about changes in pressure. This is the kind of effusion you might see in someone who has heart failure, who has had a surgical procedure of the chest, like you'll see this in post cardiac surgery, whether it be bypass surgery, valve surgery, or whatever. But you will also see this in volume overload in some patients, because remember, they're trying to put the fluid somewhere. An exudative pleural effusion is quite different, though. This is a response to inflammation, infection, even a malignancy. And so as a result then, as opposed to being a watery kind of fluid, this fluid is contains white cells, contains proteins, isn't clear. A transudative, because it's watery, would tend to look fairly clear. Exudative would look cloudy, or you wouldn't be able to read through it because it's not that watery. So because, as we talked about, inflammation or infection, so you might see this in someone who has an acute lung injury complicated by an infection. This is frequently what you'll see in someone who has lung cancer because the malignancy can actually cause this as well. So let's turn our attention from the pleural disorders to restrictive lung disorders. And there are some commonalities in restrictive disorders. In a restrictive disorder, you will usually see decreased compliance of the lung tissue. Because of that decreased compliance, which means they're unable to expand the lungs, you would see an increased work of breathing. Now, when you think about that then, which phase of respiration would this occur on? Would it be inspiratory or would it be expiratory? Correct. I sure hope you've been shouting either at the screen or while you're listening to this. It is inspiratory because it is decreased compliance. So that increased work of breathing is more on the inspiratory phase of respiration. As a result, you'll see a decrease in the tidal volume. Remember, that was the amount of air in and out with a normal expiration, as well as a decrease in the forced vital capacity. Now, a vital capacity, the forced vital capacity, is the amount of air that is forcibly exhaled after taking the deepest possible breath. And it's decreased because, remember, they couldn't bring as much in. Restrictive orders result in ventilation perfusion mismatches. So they're perfusing but not ventilating. It also will result in changes in that alveolar capillary membrane, and it's going to change that membrane so that you will end up with a decreased diffusion of oxygen, and therefore that would then lead to hypoxemia. So let's look at a couple of restrictive pathologies, and the two very common, again, doesn't matter what age your patient is, are aspiration and atelectasis. When we look at aspiration, we're generally talking about food or fluid that is in the lungs. Now, this is going to kind of weird some of you out, but you have to remember that all of us microaspirate. We all do this frequently at night, and some of it's just our own pulmonary secretions that we've brought back down. But when this becomes problematic, we're usually thinking about those individuals who have an impaired swallow or a cough reflex. So when you think about this, you'll see this both in kids as well as elders with feeding tubes. And think about a very premature infant or a very young child who has a feeding tube down, whose swallow and cough reflex just hasn't had a chance to mature yet. So you would be concerned about aspiration of food and fluid into the lungs. Certainly that also happens with elders. It may be the result of a neuropathology like a stroke, but also frequently happens with individuals who have dementia, chronic dementia. With an aspiration, pH matters. Although very low pHs can be especially harmful and lead to an aspiration pneumonitis, highly alkalitic secretions are also problematic. For example, we've seen an increased incidence of aspiration pneumonitis with changing gastric pHs in those individuals who chronically use proton pump inhibitors. Proton pump inhibitors, the goal of which is to decrease the pH of the gastric contents, then when they aspirate, that microaspiration that we talked about, or aspiration in general, when they aspirate into their lungs, that is more alkaline, and alkaline as well as acidic can cause an aspiration pneumonitis. This aspiration then, because the food and fluids don't belong there, really, leads to inflammation, can become a site for infections, and then the lungs become stiff. Let's talk about that just a little bit more, that inflammation, infection, as well as the stiffness. Remember that we have pulmonary macrophages in our lungs. So if we inactivate those pulmonary macrophages because we've changed the environment, that can lead to additional recruitment of additional inflammation as well as infection. In addition, we have surfactant in our lungs. Surfactant, although the primary role may be to increase surface tension to facilitate alveolar expansion, surfactant also has an anti-inflammatory effect as well as the role in decreasing surface tension. So think about both macrophages as well as the anti-inflammatory effect of surfactant and how that can affect stiffness of the lungs as due to that inflammatory process. Atelectasis is collapse of the airway. Remember, we're talking about still talking about restrictive pathologies. So we know that we need positive pressure in our airway in order to keep those airways open. So we can collapse those airways from compression either outside or inside. Sorry, I didn't put that on the slide. So it can be compression from outside the alveolus, or the airways themselves can collapse from the inside. This is what you see postoperatively. This is what you see in someone who may have chronic chest wall pain, or you can even see this in acute back pain. So with that compression, then you see that physical collapse of the airways. The other thing that can cause an atelectasis is either insufficient, poorly distributed, or inactivated surfactant. This atelectasis then leads to hypoxemia and also sets up a wonderful area for potential infection. Now, with potential infection is much more likely in atelectasis with atelectasis, because when it's inside the alveolus, like these retained secretions or these because of retained secretions that haven't been coughed out to clear the airway. This is why we do so much deep breathing with anyone who is post-op. But we also need to remember that if they've had anything that would keep them from wanting to take a big deep breath. Now, before we move away from this idea of surfactant, I want you to think just a little bit about pneumocytes. Pneumocytes are our lung cells. And we have two types of pneumocytes. We have type 1 pneumocytes, which is the majority. About 90% of our pneumocytes are type 1 pneumocytes. These are structural, and type 1 pneumocytes can't regenerate. However, we also have type 2 pneumocytes. The type 2 pneumocytes are the ones that produce surfactant. As mentioned earlier, remember that surfactant decreases the surface tension to facilitate alveolar expansion and therefore gas exchange. Now, what's really cool, though, about these type 2 pneumocytes is they do actually have the ability to make type 1 cells if absolutely necessary. So even though type 1 cells cannot regenerate, the type 2 cells, whose primary goal is to make surfactant, does have limited ability to make type 1 cells if absolutely necessary. The last two pathologies that can cause restriction are oxygen toxicity and inhaled particles. So let's start with oxygen toxicity. With oxygen toxicity, usually what we're looking at is prolonged exposure to very high fractional excretion of oxygen. Generally, this is over 60% and again occurs at all ages. Chronic exposure to high FiO2s, although this can be acute, it's usually chronic if it's going to cause a restrictive change in the lungs. Chronic exposure to a high FiO2 damages the epithelium and actually inactivates surfactant. So as a result, because of the damage to the epithelium and the changes in inactivating the surfactant, you now have structural changes. When we think about acute exposures to high FiO2s, generally you think about central nervous system effects, like hand or muscle twitching, seizures, things of that nature. So we're really primarily with the prolonged exposure, we're talking about someone who has done this chronically. So if you think about that then, if you have damaged epithelium and inactivation of surfactant, that then leads to a fibrotic change within these cells and within these structures. Fibrotic tissue doesn't participate in gas exchange. The last are inhaled particles, and this is the pneumoconiosis that I know you've been reading about. So when we think about silicone, coal, asbestos, talcum powder, those sorts of things, there's a substance in the airway that the body is unable to break down. This then, through a series of inflammatory and changes within the epithelium, ends up leading leading to a fibrotic change, and again, fibrotic tissue cannot participate in gas exchange. The last two things that on this piece of our time together in this first recording is to think about pulmonary edema and acute lung injury. Now, we previously talked about pulmonary edema when we talked about backflow of pressure from left heart failure. So frequently pulmonary edema is due to left-sided heart failure, but it can also be due to acute lung injury as well as inhaled toxic gases. Toxic gases like chlorine gas or what might happen in a fire. Now, in heart failure, what we see is a hydrostatic issue. So we're talking about capillary hydrostatic pressures. So in heart failure, you have an increased filling pressure on the pulmonary side. That leads to an increase in the hydrostatic capillary pressure that exceeds oncotic pressure. Because that hydrostatic pressure is greater than the oncotic pressure, the fluid moves to the interstitium. And you can't really bring that back into the vascular space. So over time, this can lead to a fibrotic change. In acute lung injury or acute respiratory distress syndrome, it's an issue of permeability. The capillary injury increases capillary permeability, which then causes leakage of plasma proteins and water into the interstitium. As a result, then, that increases the oncotic pressure within the interstitium. So heart failure, pulmonary edema from a heart failure pathology would be due to hydrostatic forces, whereas with ARDS or acute lung injury is due to increase in capillary permeability. In both of these cases, however, dyspnea and hypoxemia, as well as the work of breathing, all increase. So if our patient is dyspneic, hypoxemic, has hypoxemia, and has a high work of breathing, what's going to happen to their tidal volume? Correct, it's going to decrease. The last topic is acute lung injury. Now, acute lung injury is actually a syndrome, and look at that last bullet point on the slide because it really is important. We are increasingly changing terminology from calling something ALI or ARDS or acute chest syndrome or whatever, and we're beginning to call kind of everything acute lung injury. And this encompasses acute respiratory distress syndrome and acute respiratory failure as a syndrome as opposed to a specific disease state. The other thing that's important about acute lung injury is it's acute, therefore potentially reversible. So that's the other thing we want to remember about this. And again, acute lung injury occurs across all age ranges. So what we have with an acute lung injury is injury to that alveolar capillary membrane, which then leads to inflammation. That inflammation increases capillary permeability. Remember, we just talked about that in the pulmonary edema process. Pulmonary edema, shunting, and by shunting what we mean is we start shunting our ability to inspire air to the areas that are still working. You'll have a ventilation perfusion mismatch, which then results in hypoxemia. So once again, we are perfusing but not ventilating. Now it's important that you have an understanding of the three major phases of acute lung injury. We start with the exudative inflammatory phase, which, if we don't turn this around, leads to a proliferative phase, and finally a fibrotic phase. Let's first take a look at this exudative inflammatory phase. This is characterized by a decrease in compliance and vasoconstriction. This usually occurs fairly early, so usually within the first 72 hours. Now again, as mentioned just a tiny bit ago, there is damage to the alveolar capillary membrane. As a result, then, there is uncontrolled inflammation, and we've activated complement as well as platelets, which then damage the capillaries. So you have damage to alveolar and endothelial cells, therefore membrane damage. Neutrophils are essentially to both the development as well as the progression of this exudative phase. The other thing that's very important is surfactant. Surfactant, because it decreases during this phase, would therefore lead to decrease in gas exchange, and this is critical, and this is also occurring. So what happens then in this exudative inflammatory stage is you have leakage of this these inflammatory products, the activated complement and the platelets, into the interstitium. Because this is leaking into the interstitium, that then causes atelectasis. The atelectasis then is going to decrease compliance. Unchecked, this exudative inflammatory phase will move to the proliferative phase, and this is a fairly long phase and starts someplace around after that 72 hours, but can last as long as 21 days. So these exudative changes now become granulation tissue. Not good, right? Because we know that granulation tissue, while it may be good for wounds, is not good here, because granulation tissue is not good for gas exchange. This is what we sometimes call a hyaline membrane. Following this proliferative phase, which is fairly long, now we will enter the fibrotic stage, and this is after usually near the end of that proliferative phase, and now the alveoli are becoming obliterated and the bronchioles are becoming affected. This can, as we talked about, lead not only to an acute respiratory failure, but also chronic respiratory disease. So these three phases in this injury, this syndrome of injury, where we are perfusing but not ventilating, unchecked, will again lead to a fibrotic stage. So numerous things can cause an acute lung injury. The list is very, very long. It can be anything from a transfusion reaction to oxygen toxicity. Happens in sickle cell crisis. We mentioned that just very briefly when we did anemias, but it was pretty brief. But any number of things can actually cause this acute lung injury. So you have to be very sort of open-minded when you think about this syndrome. There is a great algorithm on page 1262 of your text, and I encourage you to take a look at it because it walks you through these three phases: the exudative inflammatory, the proliferative, and the fibrotic phase. And it pulls all of those concepts we've been talking about in terms of inflammation, in terms of the movement of complement, and how capillaries can become damaged as we move forward to this alveolar obliteration and potential damage to the bronchioles. So we've started this off by talking about the difference between hypercapnia and hypoxemia. We talked then about pleural disorders and the importance of being able to identify those differences. We moved from there to talking about a variety of different restrictive disorders, including atelectasis, including an aspiration. We talked about processes and pathologies that can lead to fibrosis. And then we also we kind of added in pulmonary edema as well as acute lung injury, both of which, if we depending on the pathology, can also lead to a fibrotic state. Thank you for your attention, and do let me know if you have questions.